Good morning. We're going to get started here in a minute. I need to know, can people see my talk? The title should be What's Special About AFIB, the AFIB program at New Mexico Heart Institute.
Yes.
That's good news. Was that Dr.? Thank you, Dr. Rai. Appreciate you this morning. Welcome to all of you guys who are not part of our usual electrophysiology group. We're really happy to have you this morning. We're going to have kind of a shorter talk this morning, and then maybe some discussion about atrial fibrillation and the program at New Mexico Heart Institute to take care of atrial fibrillation patients. We'd like to thank Pfizer for sponsoring this morning's meeting. Without support like that, we can't continue to hold educational programs like this. And of course, they had no influence over the content of the program. So I wanted to talk about the program from a global perspective, and then talk about some of the particulars that are unique to New Mexico Heart Institute's atrial fibrillation program. And I think we have in the audience this morning Barry Ramon. People may not know that it's about 55 years ago that we started doing electrophysiology at New Mexico Heart Institute. It's a long time, and Barry's directly responsible for that advance in the care of patients in New Mexico. So 2020 was a bad year for the entire world, but not a terrible year for the New Mexico Heart Institute's electrophysiology program. If you guys can't hear me, just please somebody pitch in, because it's hard to tell if you can hear well. New Mexico Heart Institute did 10% more ablations and invasive procedures in 2020 than we did at the prior year, so a total of 1,900. A large percentage of those were done by Mike Hoskins. He did, I'm told, 420 procedures last year, which is a huge number for an electrophysiologist. During the last 2 years, we've moved to a situation where all 5 of our providers are using no X-ray to do any of their invasive catheter-based electrophysiology. And I think that's a huge benefit to the staff, to the patients, and to the providers themselves. And so that's kind of a landmark. There are many things about our group that are unique. That's one of the things that's unique. And I think in 2021, we're looking forward to adding a third room to try to move some of the patients who are waiting for procedures through the hospital and program. I think the last 2 to 3 years have evolved our understanding of atrial fibrillation substantially. Atrial fibrillation, we now know, is a secondary arrhythmia, meaning that it's not a primary problem of the heart. It always comes from some other arrhythmia. And I think that what those arrhythmias are depends entirely on the individual, from a young patient with WPW who also has atrial fibrillation to an elderly patient who has PVCs and atrial fibrillation. And I think we're continuing to learn about the conditions that generate atrial fibrillation in a human. It is not just enough to have atrial fibrosis. You must have some initiating rhythm. We also, I think, have learned about the progress of the disease. I think papers starting in about 2016 have documented that this is a progressive problem in a human heart, and that if you don't intervene early enough, the patients have generally progression to persistent and then permanent atrial fibrillation. The factors that lead to progression are the factors that you would suspect: obesity, hypertension, structural heart disease of other types, sleep apnea, and the more of those features you have in your clinical presentation, the more likely you are to progress, and the more rapidly your atrial fibrillation progresses from paroxysmal to persistent. I often make the point that in the entire population at Mayo Clinic, that the population they service, when they looked carefully, they were only able to find 10 people who had really quote, lone atrial fibrillation. So lone atrial fibrillation turns out to be a relatively rare condition. And then I think I would make the point about atrial flutter. Our understanding of atrial flutter continues to evolve. I would say we should think of atrial flutter as a tertiary arrhythmia, meaning that there's a trigger arrhythmia that initiates atrial fibrillation. Atrial fibrillation converts to atrial flutter, and then atrial flutter persists because it's a relatively stable arrhythmia. So patients who present with atrial flutter, we're looking much more closely at those patients to understand whether they have atrial fibrillation, and at invasive procedure are contemplating in many cases whether treating both conditions is the right thing to do. And so there's a randomized trial demonstrating that patients who have both atrial flutter and pulmonary vein isolation, atrial flutter therapy and pulmonary vein isolation have improved outcomes by a large amount over a longer follow-up period. Of course, some of the things that are changing in our business and care are driven by technology. And so we have new mapping tools that allow us to tackle harder cases and work more quickly through the easier cases, which allows us to get to address more things during a case. And so the arrhythmias that we previously were challenged by, left atrial flutter and persistent atrial fibrillation, while not easy, are easier. And Mike Hoskins said to me the other night on a phone call, we often have phone calls on our way home, that left atrial flutter is his favorite arrhythmia now. And I think that that's probably true for maybe 4 out of the 5 electrophysiologists in New Mexico Heart Institute. And I think that and the reason you'll see is that some of the technology that we have to address them makes the mechanism of the flutter and the mechanism allows us evident, and knowing the mechanism allows us to treat the flutter very cleanly. We also have new pacing tools which allow us to find solutions for the most difficult elderly patients, and I think we'll spend just a few minutes talking about what those pacing solutions are. One of the things that made us successful last year is that our group for a long, long time has been sending patients home on the day of the procedure. We started sending pacemaker patients and defibrillator patients home on the same day in 2006 and have persisted in advancing that cause. And now our most complicated procedures, which we did about 450 of them last year in the left atrium, 2/3 of those patients are discharged, or 3/4 of those patients are discharged on the same day. And then by the next day, 93% of the patients are discharged within 24 hours. And the most common reason for people to stay in the hospital overnight is that they live a long ways from the heart hospital. And so the driving home would present a logistical challenge for them. This, I think, is a feature of our care that patients really, really liked, and particularly last year really liked because of the risk that they felt inherent in staying in a hospital environment during COVID. And so being able to discharge patients has really allowed us to continue to work in a very normal way during a very challenging time in the hospital. Of those 457 patients, 10% of them were readmitted. The average time to readmission was 15 days. So even if we had kept them overnight, we would not have discovered the problem that they needed care for in the next 2 weeks, in most cases. So who are the patients who had the ablations for atrial fibrillation? There were, again, 476. 109 had prior left atrial either ablation or surgery. And so we don't use them for trying to figure out if primary ablation is the right strategy or a good strategy for patients. I think I wanted to make the point that this 53% paroxysmal and 46% persistent, that doesn't add up to 100. That was one point I wanted to make. The second point I wanted to make was that that's an unusual balance of paroxysmals and persistence. And I think that it suggests that the patients are getting to electrophysiologists too late in the game, and we're waiting too long to intervene as electrophysiologists on their atrial fibrillation. Some of it is the rural nature and the underutilization of healthcare in our state, and some of it is just a shifting paradigm of care. And I think our challenge as a group at New Mexico Heart Institute is to try to move that number closer to 3/4 to paroxysmal and 25% persistent. And the ways we can do that, right? Good care of patients, rapid referral of atrial fibrillation patients when they present with atrial fibrillation. And then if the interventional person could bring them to the lab sooner, that is better for the patients. The average CHADS VASC is 2.6, and I think that's pretty normal for a large ablation group. I think we still have about 15%, 16% of people who are on warfarin. That's still a number that we're working to drive down. The warfarin is for sure a less safe drug for intervention than either Eliquis or Xarelto. Of course, Eliquis is the safest of those drugs. And the reason that warfarin is less safe is that the way that warfarin works, right, it interferes with the formation of clotting proteins. And so if you have fewer clotting proteins, you're more likely to have a bleeding event when you have an interventional procedure. And so all of our patients, we should be pushing away from warfarin if it's possible, either on a health or insurance basis. The average left atrial volume, this goes to this 46% persistent, is 155. Again, in our way of measuring the left atrial volumes, we use the mapping system to measure left atrial volume. Normal is between 60 and 90 cc's, and so people who have a group that has a average volume of 155 is obviously not in a good position. The physicians rate the health of the left atrium based on volume and voltage at the time of the procedure, and that average Utah class, that's the name of the scale that we use to assess the volume, was 1.7, and that score goes from 1 to 4, 4 being a large amount of fibrosis, more than 75% fibrosis. Many of you may not know, but Dr. Poku did some of the groundbreaking research on left atrial fibrosis when he was at the University of Utah. So he's our local expert on atrial fibrosis. So these are the outcomes of those patients who've gone for ablation. And this is excluding people who've had prior ablation, and it's 1 year rates of freedom from atrial fibrillation. And what you can see is that the people who have paroxysmal atrial fibrillation, their chance of having recurrent atrial fibrillation is relatively low, about 91%, whereas the people who have persistent atrial fibrillation have a recurrence rate of about 80%. What's notable about atrial fibrillation procedures in general is that there are two ways you can recur. One way is with atrial fibrillation. A second is with either your incident arrhythmia, meaning the primary arrhythmia that generates your atrial fibrillation, or left atrial tachycardia as a result of the initial intervention, the scar tissue that's formed at the initial intervention. And I think it's a mistake to assume that every recurrence of atrial tachycardia is related to the incident ablation. Remember that we take away the mechanism that allows the heart to go into atrial fibrillation, but we do not take away the incident arrhythmia sometimes. And so if we don't see the incident arrhythmia at the first procedure, we won't be able to address it. And that is something that happens quite frequently. And so the atrial tachycardia and atrial flutter recurrence is a mixed bag in that group. Some of those people have their incident arrhythmia or primary arrhythmia, and some of those people have an atrial tachycardia that's a complication of the ablation. And it's hard to know, honestly. We don't spend a lot of time trying to figure out which one is which, but it's worth remembering that there's a distinction there that needs to be maintained. Of the patients, all the larger group of left atrial patients, there were 10 total complications. If you add up the 2, 1, 2, 5, 2, 1, that adds up to more than 10, and that's because some people who had pericardial fusions or pseudoaneurysms needed repair of those problems with surgery, and so they're counted twice in the list below. And so a complication rate of 10 patients is about 1 in 50, which are 1 in 48, which is a reasonable number when you're talking about the level of intervention that we're talking about, with 1 death in the 476 patients. So some of the new tools, we'll look at maps made with the new tools here in a second. We have a tool called ripple mapping, which allowed us to map the actual wavefront and the progress of the wavefront, as well as the complexity of the signals on a 3-dimensional map. And it's used widely for left atrial tachycardia mapping, but used here at New Mexico Heart Institute for a technique called, that we call ripple mapping for rotor driver mapping in persistent and paroxysmal atrial fibrillation. And we can talk about that if anybody's interested in that. I'll show you an example of it. And then coherence mapping was released in 2019, and it's an update to ripple mapping, which allows us to look at areas of slow conduction that might be perpetuating an arrhythmia. And it's used exclusively for left atrial tachycardias at this point. And I'll show you some examples. So this is on the right-hand side. This is the coherent map. The colors represent timing of the electrograms, and the colors, of course, are interpolated, meaning that the computer is deciding how to assign the color. And then on the right is the ripple map. Sorry, I'm left-right blind. This is on the left, and I don't know if can you see my mouse? You can see my mouse. That's great. So on the left, you can see a scar map, and we'll play the ripple map against this scar map so that you can see the pattern of progression of the atrial electrogram or atrial wavefront. Let's see if we can make it play. And so you can clearly see the wavefront traveling around the heart in a figure-of-8 pattern. And I think these tools have made manifest what was previously only hypothesized. We talked about figure-of-8 tachycardias, and we hypothesized where the circuits might be, but only when we were able to do these kind of maps were we able to actually make manifest so that we could see where the atrial electrograms were going and where the areas of slow conduction are. And I'll play this again. In the coherence map, you can see these large arrows here are the slow conduction arrows, and they demonstrate the arrhythmia going through this channel and up the posterior wall, and then the 2 loops meeting again at the bottom. Anyway, these maps, I think for an electrophysiologist are sort of paradigm changing, because where we couldn't see or imagine, we had to imagine what was going on before, we can now really make manifest. And so ablation at that blue dot terminates this arrhythmia with 1 lesion. It's an incredibly satisfying thing to accomplish. In previous generations or iterations, it took often multiple lines and hours to accomplish. And the map takes 25 minutes to make, and the lesion takes another 2 minutes to make. It also showed us that there are tachycardias that have mechanisms that we didn't suspect. And this is an example of a tachycardias with mechanisms that we didn't expect. This tachycardia, there's an ablation line here, and the tachycardia jumps the ablation line using the ligament of Marshall, which is an epicardial structure, and I'll show you another example of that. And it turns out that that's a common mechanism of tachycardias that we didn't know existed until we had a way of mapping it. And the epicardial structures of the left atrium turn out to be a difficult part of eliminating these arrhythmias. So again, this is that line here, looking in the left-hand screen, and that tachycardia jumps over that line by going up the ligament of Marshall, which is, again, on the outside of the heart. Remembering that this map is at the inside of the heart, so you won't be able to see it jump it, but we know from looking at that that's where that structure is, and so that's how that gets up the left atrial appendage. This is another example of that kind of tachycardia, except this time it's a figure of 8 with 2 loops coming down the ligament of Marshall and jumping over this line, and you'll see the tachycardia emerge beyond the line here. And in coherence map, you can really see it very well. This lesion set sometimes fixes this tachycardia, but sometimes we need to do other things. And that I think Dr. Hoskins and I have grown interested in ways of addressing this, and we'll talk about it in a moment, with alcohol ablation. And then this is a ripple map, and you can see in the bottom of the screen the electrograms. The person goes from atrial fibrillation to atrial tachycardia ablating at a ripple site. And then on the next page, you'll see that atrial tachycardia convert to sinus rhythm, ablating at a second ripple site in the ligament of Marshall here at the base appendage. So one of the ways we can address this ligament of Marshall is part of the uniqueness of New Mexico Heart Institute's program, is that collaboration between the electrophysiologists is routine. And so Mike Hoskins has done this before. And so we've worked together in the last couple of months to use this technique of ethanol ablation in the mitral isthmus in the vein of Marshall. And this is the vein of Marshall here, this tiny little vein that goes up the space between the pulmonary veins and the left atrial appendage, and inject that small vein with ethanol, creating a large area of scar and eliminating the epicardial connection that is perpetuating some of these arrhythmias. When we have ligament of Marshall tachycardias, sometimes endocardial ablation works and sometimes CS ablation works, but there are times when neither work. And having this tool is another way that we can help our patients. And in the last month, we've done 3 in the heart hospital lab successfully. And in each case, I think the patients were helped by that. This is a voltage map. Purple is healthy for the uninitiated, and green and red and gray are tending towards scar. This is where the ligament of Marshall exists in this crease between the appendage and the veins. And this is what this amount of scar that injecting that vein of Marshall creates. It creates a large area of scar around the vein and between the 2 structures. And so it's a very helpful tool in establishing or eliminating those ligament of Marshall tachycardias. As part of the atrial fibrillation program, stroke prevention, of course, is a huge piece of what electrophysiologists do. And our Jeff Kuntz, who's one of the interventional cardiologists here, and myself started the Watchman Program in 2006 and 2007 as part of the original clinical trial. In 2016, the tool was released for widespread use, and the Heart Hospital has done a total of 365 cases in the last several years and 240 in the last 2 years. And I think our Watchman experience continues to grow. Similar to the ethanol ablation, we've had a few patients who have problems that are so difficult that they needed a solution that only a few people can provide in the United States. And so the 5 patients who've had leaks and no clot behind the device, who had absolute contraindications to anticoagulation, for those patients, they needed the leaks closed. And so Dr. Hoskins and I have done 5 patients, coiled the leaks and closed the leaks in 5 patients, which I think is something that can only be done in a few places in the US. This is a case that we did using intracardiac ultrasound in the left atrium and 3-dimensional mapping to help us identify the leak and to coil the leaks. And I'm hoping you can see the leak is in around the edge here of the Watchman, and it's been marked by the person managing the ultrasound. This is the 3-dimensional map, and the left atrial appendage is on the far side of the ultrasound image. And this is the sort of pre-procedure evaluation, and then this is post-procedure after the leak's been closed. You can see that that edge is now opposed and that there's no leak on that side. And again, using all of these tools together, I think probably we're the only place in the United States using all of these tools at the same time to close leaks like this. And I think it's a tool that has benefited a handful of people here in New Mexico. This last month, we moved to the new generation of Watchman, which is called Watchman Flex. And it really, I think, does represent a significant improvement in the tool. It's a device that can be recaptured multiple times. It's softer, meaning it's less likely to cause injury to the left atrium. And it has fewer leaks on the edges because it has many more struts and much deeper fabric cover. And so the device is more effective at closing left atrial appendages without leaks. And so I think it's going to be, I think this device is going to advance the care of patients even further. There were a handful of cases with the other device that were either suboptimal or impossible to do. And we're now able to do those cases, I think, much more safely and much more effectively. The lariat procedure continues to exist at the Heart Hospital, and it's, I think, undergone evolution in the last 2 years with Mike being here. And right now, we are able to provide it as part of the continuing access program in the AMAZE trial. And New Mexico Heart Institute is tied for the lead in the United States for enrollment in that trial, and so, or continuing access program. And I think we've done 6 total cases in the last 12 months and have many more scheduled. I think this tool represents a unique opportunity for patients because there are patients who can't even be on temporary anticoagulation who can get this procedure. And also, I think there's a chance that the left atrial appendage removal will prove to be therapeutic for patients with persistent atrial fibrillation. That's the hypothesis that the AMAZE trial is testing. So in 2012, we were one of the first programs in the US to institute His bundle pacing. So what His bundle pacing is, roughly speaking, is using the native conduction system of the heart to activate to continue to activate the ventricles and inserting the pacing lead into the conduction system at the most proximal portion in the ventricle. I think that there are some natural problems with His bundle pacing that prevented widespread adoption. And so in March of 2020, we started a procedure called left bundle pacing, which was really innovated by a group of Chinese physicians in Beijing. And since then, we've been doing almost entirely left bundle branch pacing. And basically what that involves is, instead of plugging our lead into the proximal His-Purkinje system, we tunnel the lead across the septum into the subendocardial left bundle branch. and use the left bundle branch to activate the ventricle. This allows preservation of the LV normal conducting tissue, and should preserve ejection fraction, or in some cases be better for the ejection fraction for patients who have congestive heart failure. So I think we're probably the only place in the United States where all the providers are able to do left bundle pacing. And I think, we'll continue to be involved in evolving physiologic pacing. In the last year, we've done 104 cases with a 97% success rate. And in general, left bundle pacing creates a situation where the thresholds are better and the sensing is better than his bundle pacing. So this, I think, represents a substantial innovation in pacing. And we have an example. I have an example of the EKG post left bundle pacing. This is a patient who had left bundle pacing yesterday. And I think what's characteristic about these patients is that they have a right bundle branch block pattern on their EKG, and they have very narrow QRSs without the RV-LV fragmentation that you see with pacing in most situations. I don't know how narrow this person's QRS is, but maybe it's 100 milliseconds or so. Anyway, this kind of intervention, I think, represents a substantial evolution in how we address patients with AV block, and we can really help them tremendously. For patients who have difficult to control atrial fibrillation, AV node ablation and left bundle pacing offers really an immediate out of that situation and freedom from the symptoms that persistent atrial fibrillation often causes in old age. And so, again, I think a pretty remarkable change in our practice pattern. So just to summarize some of the things that NMHI has been nationally recognized for. We continue to be a site for advanced ablation training for people who are out in practice, one of 10 sites in the US like this. We're one of 3 sites for physiological pacing training in the United States. When Abbott was releasing his bundle catheter, they asked us to roll it out here and to help them to just develop the instructions for use and the implant techniques. We continue to be a center for device extraction training, and in the top 10% in the US and device extraction, thanks to the 2 Mikes. That's Mike Bastaros and Mike Hoskins. And we're part of a worldwide advisory panel for advancing 3D mapping to do left atrial appendage closure devices using intracardiac and left atrial echocardiograms. And we're in the process of applying for an advanced fellow in GME at UNM for interventional cardiac electrophysiology. And so that person hopefully will start in 2022, summer of 2022. Just for those who haven't seen it, we were the EP Lab of the Month in March. So that was a nice thing to have, a nice honor for us. I'm going to open it up for questions. I think there's some opportunity for discussion. I know we have a lot of general cardiologists here today, which I'm really thankful for. And of course, I'll take any questions. So Dr. Poku, that is Dr. Michael Poku, asked, do we routinely do imaging, cardiac imaging prior to the procedure? And the answer is, starting in about 2013 or 2014, the intra-procedure imaging techniques became so advanced that it seemed redundant in many cases to do those either cardiac MRIs or cardiac CTs. So right now we're not doing them. I do think that Dr. Poku's an adult congenital specialist, And so I do think that for people who are coming to the EP lab for adult congenital cardiac procedures, we should be doing them. But I think for the routine atrial fibrillation ablations, we're not going to do them just because of the radiation exposure and dye exposure. That created some complications for people. And so avoiding that has, I think, proved to be the right approach.
Experience in ablation patient with metallic prosthetic mitral valve.
So Dr. Boku asked about our experience with prosthetic valve patients that have metal valves. And I think there are a couple of things I would say about it. One is that we have a pretty extensive experience with patients who have St. Jude valves in the mitral position because of the nature of our surgical practice, and also because of the nature of sort of maybe the right way to say is late referral for atrial fibrillation ablation. And so I think those patients do fine with ablation. Because they have prior heart surgery, the risk of effusion is very low, and the risk of entanglement with the valve with the catheters we currently use is essentially zero. So I feel really no hesitation at all about doing atrial ablation on those patients. So that's, I think, a change from maybe from 2011, 2012 period.
We can go either retrograde or anterograde to be able to get anywhere.
Right. Mike Bestaros makes a great point. We have a tool called Stereotaxis available to us, which allows us to use a very soft catheter. And we have on a number of occasions where a person had either an ASD closure device in that would prevent us from crossing the septum. We've gone retrograde through the aorta, back through the mitral valve to do atrial fibrillation ablation, or people who have interrupted IVCs and so no access to the right side of the heart, we've gone retrograde to do those ablations. We have the ability really to reach any of the chambers in almost really any circumstance. And I think that, again, that's a relatively unique situation in our lab because of the tools that the hospitals provided. So we've had a handful of patients with interrupted IVCs. It depends a little bit on their anatomy, but we can either approach them from the arm with a Stereotaxis catheter, or retrograde if they have atrial fibrillation from the aorta, so that we can get into their aorta through the LV, through the mitral valve, and back into the left atrium, right? Because the catheter is soft, it doesn't have you can make an unlimited number of bends in the catheter before you get to the ablation location that you're in, the site of eventual ablation.
Can you comment on how that came to be?
So Mike Hoskins makes the point that the Xray-free ablation is very unusual in the United States, and it's hard to express how unusual it is. But the tools that have allowed us to do that are the three-dimensional mapping tools and the intracardiac ultrasound tools that we have that are really unbelievable. And I think we have a person in our group who has such a skill with ultrasound that he's really taught all of us. In fact, last week he was teaching us yet another skill. Mike Bestaros has a really unique ability to image the heart with intracardiac ultrasound. He doesn't appreciate how unusual it is. Luckily for us, because then he might go on the free agent market. But no, truthfully, he's world class at that, and that has allowed all of us to innovate our technique and be able to provide X-ray free ablation for patients That means, you know, young women who are pregnant, people who've had extensive X-ray exposure in the past. All those people have really no worries about coming for ablation.
You know, having recently finished fellowship, I think it was routine that AFib ablations would have 20 minutes of X-ray time, and I don't think there's any chance that combined as a group in a year and a half that we would have that total. You know,
right.
All the patients that we
I don't know if you guys can hear, but Yao Poku mentions that in his training program at Beth Israel Deaconess, it would be routine to have 20 minutes of X-ray exposure in one case, and it would be very unlikely that in our entire group for an entire year we would have 20 minutes of X-ray exposure for ablation procedures total. So it is a really tremendous difference in terms of X-ray use. We have a question from Dr. Bay to everyone about pulse field ablation for pulmonary vein isolation. I'm not sure what pulse field ablation is, but I'm going to assume that it's electroporation. And electroporation is a technology that's coming to probably widespread clinical use. There are IDE trials available in Europe right now with electroporation. We always try things on French people first, and then they'll come to the US. It'll come to the US probably a year from now would be my guess in clinical trials. The problem with electroporation is it's been easy to make a lesion. It hasn't been easy to make a lesion that's transmural, meaning through the whole wall, and that stays dead. And so there's a problem with reconnection with electroporation. So I think the companies are still scrambling. I think every major ablation company has an electroporation tool. And the question is, which one will figure out all the details fastest?
Collateral damage.
Right. I mean, the promise is less collateral damage. What we previously have seen is that the heart is touching lots of things, and if anything that damages the heart there's a risk of damaging things nearby. That continues to be a questions from any of the general cardiologists or comments. We'd welcome them. Yeah, I think something that might be news to people, Dr. Nair, who's one of our electrophysiologists, mentions, is that we no longer use needles to cross the septum, the interatrial septum. We use a soft J wire and a little bit of electrocautery. And that has been one of the changes that allowed us to go to an Xray-free environment because of how safe the J wire is as a tool to cross the septum. I think one of the things that we know as electrophysiologists is that there are tons of smart people out there in the world, not just in the United States, and to really have made an effort in the last 15 years to go out into the world and find the most innovative people and to spend time in their labs and innovate our techniques here. And I think that has been one of the most satisfying parts of being an electrophysiologist is that constant innovation. I mean, every single quarter there's some new technique. It's remarkable.
Give me 30 seconds.
Dr. Poku is doing analysis on the fly of how many patients are on antiarrhythmic drugs post-ablation. It's actually probably a minority. I think our tendency is to stop antiarrhythmic drugs in general. there used to be this idea of early recurrence of atrial fibrillation post-ablation was just an artifact of the injury to the left atrium. And I think in point of fact, it's proven over and over again that if you have early recurrence of atrial fibrillation, it usually means that the intervention was unsuccessful. And so those people don't respond particularly well to antiarrhythmic drugs either, because they didn't respond very well at the beginning. That's not to say never, but it's I think it's relatively uncommon. And yeah, you can share it with us when you find it.
Less than 10%.
Yeah, so less than 10% total remain on antiarrhythmic drugs after ablation, which that sounds right. You know, again, I think this idea of early recurrence of atrial fibrillation after ablation, I think there was a time when people accepted that as part of the normal healing process of atrial fibrillation ablation. But I think we're coming further and further along to understand that if we have somebody who had a really successful ablation, they're generally non-inducible at the end of the procedure, and we generally don't see atrial fibrillation again ever in those patients. And we know that it's like arthritis of the knee, right? Like no one goes to their knee surgeon and says, "Can you cure my arthritis of the knee?" Right? Like we're trying to, in a lot of cases, we know that we're managing the atrial fibrillation for the patient over a 10-year period or 20-year period. And that management may mean that 10 years from now, we have to do another ablation, right? And that there may be periods of time where they're on antiarrhythmic drug or anticoagulated. But managing it is, for many of them, means that they have preserved function in the same way that the people who have arthritis of the knees have preserved function by managing their arthritis. There are people we can cure, but they tend to be in the paroxysmal group of atrial fibrillation patients.
Most commonly is for long-standing persistent because they continue on antiarrhythmics. Yeah,
I think for sure that's true, right? I think if that 10% of people are the 10% who are the hardest atria, you know, the largest atria with the worst fibrosis and most likely to recur. Yeah. Again, I think building structure systems that channel patients to therapy for their atrial fibrillation if they want it earlier is better for the patients and over the long haul. And I think we have substantial evidence to support that. Well, thank you guys for coming today. I appreciate your attention, and I think everybody's gonna get to work.
Can you, are you off Zoom? Sean? Oh.
I am.
Because I don't know who Phil and Tiff is. Ask who's Phil and Tiff.
That's a patient, I think. Did you invite patients?
No, I did not. No. Summer's trying to figure out who Phil